Good morning or good afternoon, everyone, and welcome to today's webinar. This webinar is brought to you by Makerere University, Johns Hopkins University Research Collaboration based in Kampala, and the Global Health Network. Today, our topic is addressing congenital anomalies and triple surveillance on the path to meet the SDG 3 targets. My name is Philippa Musoke, and I am a pediatrician based in the Department of Pediatrics and Child Health, Makerere University, and the PI at Makerere University Johns Hopkins Research Collaboration. We are delighted to be joined by expert panelists today. Dr. Ornel Linsetto is a Senior Medical Officer, Newborn Health Department of Maternal, Newborn, Child and Adolescent Health in WHO, Geneva, Switzerland. And we have Dr. Lorenzo Botto, Professor of Pediatrics at the University of Utah, School of Medicine, pediatrician, pediatric cardiologist, and medical geneticist. He's the Center Director for the International Clearinghouse for Birth Defect Surveillance and Research. So we're really honored to have our experts with us today. Today we'll be discussing mainly about congenital birth defects. We'll update the burden and causes of congenital anomalies and their contribution to child mortality. We'll also look at current programs for newborn care that include prevention and care for congenital anomalies. We'll also look at the benefits of triple surveillance with the overall goal to prevent what can be prevented and treat optimally what cannot. So, Sub-Saharan African Congenital Anomalies Network. Those who are new to this network may be asking, because it is a new network. It's a seed project to establish an Africa Congenital Anomalies Network funded through UKRI MRC. The primary aim of the network is to improve the diagnosis of congenital anomalies and care for children and families affected with congenital anomalies and promote the identification of their causes by building an evidence base through surveillance and research, improving capacity for collaborative research, and paving an impact pathway on policy and practice. The network establishment is led by a team of co-investigators and partners working together with partners from 10 African countries and the United Kingdom. Together, we aim to establish network, build capacity by training of health professionals with webinars and other resources. The Sustainable Development Goal aspires to ensure that their well-being for all children in countries aiming to reduce neonatal mortality and end preventable deaths of newborns and children under 5 years of age by 2030. Congenital anomalies cause death and disability, as well as affect the health of communities throughout the lifespan. Meeting this challenge effectively requires addressing both the problem and the branches, as the root and the branches, the causes as well as the outcomes of congenital anomalies. Triple surveillance and triple action provide a framework to concurrently understand and address risk factors, occurrence, and health outcomes. So the aim of the webinar is to provide an update of the burden and causes of congenital anomalies and their contribution to child mortality. Describe current programs for newborn care that include prevention and care for congenital anomalies, and to discuss the benefits of triple surveillance with the overall goal to prevent what can be prevented and treat optimally what cannot be prevented. So that's why we're here today, and we have our experts, and we thank them for offering their time to be able to present the important data. So we'll move to the first presentation, which will be Dr. Ornella Lincetta. I've already shared, is an Italian neonatologist, pediatrician, and public health expert working with WHO in the Department of Maternal, Newborn, Child, and Adolescent Health and Aging, Geneva, Switzerland, as a senior medical officer. She currently leads the department's work on newborn health policies, practices, and programs, as well as the work on birth defects, and coordinates ENAP activities on behalf of WHO. She's been with WHO since the year 2000, and she brings experience from Laos, PDR, Vietnam, Papua New Guinea, and Bhutan. Before joining WHO, Dr. Lincetta worked for various maternal and child health projects in fragile Asian and African countries. You're very welcome. Please, Hopkins.
Thank you very much, Professor Musoke. Thank you for the introduction, and I'm very pleased to be with you today for make a brief presentation on how we can meet SDG 3 by tackling child mortality due to congenital anomalies, with a special focus on sub-Saharan Africa. And I'm very happy to see the initiative because it's really one of the areas where we have the biggest gaps. So I think overall we are with the Sustainable Development Goals in a favorable global health context for discussing the birth defects. The SDG aspires to close the equity gap, so no one is left behind, and also they are aspiring at ensuring universal health coverage, which means for everybody, including the families affected by birth defects. We also have the global strategy for women, children, and adolescent health that are in support of the Sustainable Development Goals and looking not only at survival, but also at thriving, meaning looking at for children to develop at their best possible way. And this is very important for those children who are affected by birth defects. And finally, we have the Every Newborn Action Plan, which is very much focusing on reducing neonatal mortality rate and stillbirths in countries. You see the targets here. And of course, we all know that birth defects represent a proportion of neonatal deaths and stillbirths as well. So what are the birth defects? In short, the birth defects or congenital anomalies are structural or functional anomalies that take place during the intrauterine lives, but they can be identified even prenatally. They might, many times they are identified at birth and sometimes also later in life. As we heard before, they are an important cause of stillbirths, neonatal and childhood morbidity and mortality. And because of this, they contribute also to, because of their frequency, they contribute also to chronic illness and long-term disability. So the result is quite a considerable impact for individuals who are affected, for their families, but also for the healthcare system and the society at large. For many, one of the challenges that we are facing with addressing the birth defects is that in many cases, up to 50% of cases, we don't know really the factors behind them. But on the other side, we know that there are a number of factors that can cause birth defects, and some of them are actually can be addressed. So we have genetic factors, we might have environmental factors, like, for example, radiation. We have socioeconomic and demographic factors that are not fully understood, but very important for in terms of numbers and also distribution of the birth defects. We have infections, for example, Zika, rubella, and congenital syphilis, and so on. Many of them are preventable. And then we have the maternal nutritional status, which is also very important, for which we have some programs like food supplementation and fortification, folic acid supplementation and fortification. So if you look, if you think about the causes of birth defects, and you look at the map here that shows the global burden of birth defects, so you can see that in the countries that are highlighted in red, in orange, and even those highlighted in yellow, are those where the prevalence of birth defects is higher. And these are also the countries where malnutrition is higher, where the social and economic development is lower. Just to, and probably also where the surveillance system is less developed. So, and in these slides that looks also at the burden in another way, I want to show how, I want to show a bit how the proportion of birth defects changes with as a proportion of causes of under-5 mortality changes with the level of under-5 mortality. So you see different bars. Each bar represents a region. So we have the African region on the left and high European region and high income world more on the right, less developed on the left. And then you see each bar has 3 colors where the birth defects are represented with the pink color. This is a proportion of death due to birth defects. In pink, the proportion of death due to prematurity in blue, and then those proportion of death due to birth asphyxia and birth trauma in gray. And you see the line, the red line. The red line shows the overall under-5 mortality in the year 2016. And you can see how when the under-5 mortality is highest, for example, in the African region, Eastern Mediterranean region, Southeast Asia region, the proportion of death, under-5 deaths due to birth defects is the lowest. But as under-5 mortality decreases, then the proportion of death due to congenital anomalies increases. And this is very important for you, even in the African region where the proportion is relatively smaller, to think about what would be your needs in the future. It's not only the needs today, but as you reduce neonatal and child mortality due to infections, for example, you will have a highest proportion of neonatal and child mortality due to congenital anomalies. And this is important to plan your service for the next 5, 10, 15 years. Another important challenge that we have is that we know only the upper part, let's say, of the iceberg of birth defects, this part that is easier to be measured, which is prevalence based on neonatal, infant, and under-5 mortality. We know much less instead about the lower part of this iceberg, which is more what is the proportion of deaths due to birth defects among stillbirths or spontaneous abortion, for example, as well as we know much less about the comorbidities, the results of medical surgical treatment and hospitalization, as well as the impact in terms of long-term disability, quality of life, not to say social emotional impact and economic cost for the families. These are much more difficult metrics to be measured and therefore are evaluated less frequently, but are extremely important, of course, for families, but also for the society. Then we have also other challenges in this area of birth defects, like lack of visibility of this problem in the programs, low priority, often due also to stigma, and then the fact that many countries where these birth defects might be more prevalent are also have weak health systems and also weak social systems to support the families. And at the same time, birth defects is not like an infection that you treat just with an antibiotic. It is something that requires often continual care. And this is also represent a challenge because requires addressing birth defects require functioning systems. And because of all that, the World Health Assembly resolution passed in 2010. The World Health Assembly passed in 2010 a resolution specifically on birth defects to try to promote primary prevention and also to improve the health of children with these conditions, and especially focusing on 4 areas. One is the development and strengthening of the registration and surveillance system, because this is must be at the core of the intervention on birth defects, but also developing expertise and building capacity in countries, strengthening the research and studies to understand better the etiology, the diagnosis, and the prevention and care for these conditions, and then to promote international cooperation. And so since then, we have been working with our partners to try to advocate and highlight this area of work. In terms of surveillance, we will hear more from in the next presentation, but just to say that we have developed a birth defects surveillance toolkit and case definition that, and we are using them to build capacity for better surveillance together with our partners. In terms of prevention, we have some vertical programs, but also, like, for example, folic acid fortification and supplementation to address the spina bifida defects. We have programs on elimination of congenital rubella syndrome with the vaccination, the mother-to-child transmission of congenital syphilis by better identification of syphilis in pregnancy. And then we have, of course, more integrated approaches into prevention through antenatal care and even preconception care. In terms of care of affected children, babies, we are promoting the identification and management of birth defects as integrated into the maternal, neonatal, and child health programs. I will talk a bit more later on that. And more recently, we have established also a technical working group on birth defects to ask the technical for advice on how to provide addition, how we can be more active on the areas on which we can work more or better in order to advance the agenda of birth defects. On detection, a report of birth defects, this is a key step, and I'm not going in detail here, just wanted to show that we had you are probably familiar with the birth defects surveillance atlas that was published several years ago on and looks at the visible birth defects, if you like, helps country to classify the visible birth defects. But then we have last year launched a second edition of this document, which we rename a quick reference handbook of selected congenital anomalies and infections, which includes also some internal defects like cardiovascular defects, genital urinary gastrointestinal defects, as well as congenital infections. Then I would like to spend a few words on the need of a continuum of care for those 1.3 million newborns, which are estimated to be born every year with birth defects. And you see very many blocks here. I hope it's not confusing, but actually represents the 2 continuum of care. On one side is a continuum from pre-pregnancy to pregnancy, labor and childbirth, the postnatal period, and the childhood time. And on the horizontal side, and on the vertical side, you can see the community level. You can see the first and secondary level facilities, and then in blue, the referral and tertiary level of care. At each of these points of care, there are opportunities to address the birth defects. Really, they are. And so it is very important, independently on the development of a country, it's important to look at this, framework, this different element, points of care, and think what we can do better, what we can add in order to better respond to the needs of children, babies and children, families affected by congenital anomalies. And this means to improve the detection of birth defects, means improving the referral, improve the safe transport, because without safe transport, some babies will not be able to undergo any care, because simply they arrive too cold, for example, and then they will die. And then means also to provide the care and follow up later on. Now, we have in the past couple of years worked on the concept of expanding access to quality maternal newborn care services in general, and specifically for birth defects, this is crucial. And here you can see 3 documents we have developed where we have incorporated the issue of birth defects. So one is the Every Newborn Action Plan new targets and the milestones by 2020 to 2025 to accelerate progress towards the reduction of newborn deaths and stillbirths. And here in particular, the targets are related to antenatal care, again, childbirth care, the postnatal care, which means also identify the birth defects, and improving care for small and sick newborns, which of course includes babies born with birth defects. Then we have the Survive and Thrive document, Transforming Care for Every Small and Sick Newborn, where you will find data on birth defects. You will find what we recommend in terms of expansion of services. And it's very, from the health system perspective especially, but also from the family's perspective, and how we can transform the service in order to be more inclusive and incorporate birth defects as well. And then the standards for improving the quality of care for small and sick newborns in health facilities, which provide countries with a guidance on how operationalize what we have written in the Survive and Thrive report in terms of how we can really develop those services, especially a secondary level, primary and secondary level of care, which will allow to identify and provide initial management and the referral for the babies with the birth defects, among others. And the framework that we want to share this, because I think is relevant for the birth defects as well, which is the quality of care framework to which the standards are related, is a framework that is within the system concept, but looks at the quality of care from through 8 domains. 3 are on the provision of care and look at the evidence-based practices, information system that are actionable, and functioning referral system. All of that is very relevant for the domain of birth defects as well. And then the experience of care, which means for us, there are standards really well defined on effective communication. And you know how important it is also communicate properly to parents when the baby is born with the birth defects. Respect, protection, fulfillment of newborn rights, and preservation of dignity. This is crucial also, crucial standards on birth defects. Emotional, psychological, and developmental support, again, very relevant. And finally, the 2 domains of human resources. We need the competent, motivated, and empathetic multidisciplinary human resources, and the physical resources for managing those babies. This is relevant for any small and sick newborn, including those with birth defects. And finally, at upstream, I think it's very important to remember that we need to continue to advocate to ensure that the birth defects are integrated into the maternal and neonatal child health programs, which means to have them reflected in the policies and national policy plans. Sometimes they are not visible, but now we have to make them visible using the SDG, one left behind the type of advocacy and conversation and principles. And then we needed to strengthen the, to improve, build capacities to manage the birth defects but also to capacity on surveillance. We need to establish centers of excellence for the management, because birth defects are relatively rare. And so it requires a lot of technology sometimes, not all, but some. And so it's very important to create centers that can provide care well, and are also center of excellence in terms of capacity building. And then we need to strengthen collaboration and networking. A lot can be done through collaborations and through learning from other partners. And the example of this new initiative in Africa is really good. And then families. It is very important to involve the family as partners. Sometimes, and they can be also miracles. They can make miracles in this area. In all the difficult situation for newborn babies, I saw families, family champions, family associations can help a lot. And we as clinicians or as healthcare providers, as policymakers, need to partner with the families to demand the better services. Social services, we need to work also on this area, because these babies then become children. They also need, and their families also need support. And then I'm not talking more about the surveillance system, that will be presentation. And finally, so just to say as a conclusion that the Sustainable Development Goals now represent an opportunity to address the growing and hidden burden of birth defects, in order to be able to improve the survival, but also the quality of life and the well-being of the children with birth defects. We need to strengthen, one, the surveillance system, and two, expand the access to quality maternal, neonatal, and child health services, even reproductive health services. And then if we really manage to include the birth defects in the global and national priority, then we will be able to fulfill the commitments to the Sustainable Development Goals, but also to improve the quality of life, the situation of millions of affected children and families. Thank you very much.
Thank you very, very much, Dr. Lorenzetto. We really appreciate your broad overview of, excellent overview of birth defects and the challenges over time, and how we can improve the care for our children and also reduce the SDG 3. So we'll go straight into the next presentation, and I'll ask people to write their questions and answers in the chat, in the Q&A section, not the chat, in the Q&A. If you have questions, we'll address them together. Our next presenter is Dr. Lorenzo Botto, a pediatrician and a medical geneticist. Dr. Botto sees and cares for children and adults with congenital and genetic conditions. As a public health epidemiologist, he has been working for over 2 decades with the International Center on Birth Defects of the ICBD-SR to help countries and teams worldwide to address the challenge of birth defects and rare diseases through capacity building and training. Dr. Botto, over to you. You're very welcome.
Yes, so thank you very much, Dr. Musoke, and welcome everyone. I hope you can hear me and see my screen. I wanted to take the lead from Dr. Lincetto and continue the conversation about what we can do in public health to improve the health of children and adults with congenital heart anomalies. And I would like to take the view of what we can do through surveillance. In this webinar, I would like to explore with you the concept of triple surveillance. It is a simple concept in theory, but it really hasn't been applied in practice. And I'm hoping that perhaps you, as the sub-Saharan Africa network, will be able to be the leaders in such an approach. What does triple surveillance and action what actually does it mean? I see it as an integrated approach to saving lives and reducing health inequalities. I think it's always good to start when we talk about surveillance to remind ourselves of what public health surveillance actually is. The sort of historical, important, and technical definition of public health surveillance you see here on the left of the slide, and let's go briefly through it. It is the collection, analysis, and interpretation of health data. So it's not only the collection, but also the analysis and interpretation of health data. And notice that we're talking more broadly about health data, not only about the prevalence of certain conditions, and we'll get back to that quite soon. Other important issues is that this action is systematic and ongoing. So it's not only a one-time survey, but it's something that is being tracked over time. What is the content of this? Well, it is up to us to decide what the health data being surveilled is. The important thing is that it is essential to the planning, implementation, and evaluation of public health say practice. So it's something that in some way every country, every region, every network has to decide what it is, because it's important to them. The last point is that this information has to be shared with those who can do something about it. So it's the interpretation, collection, analysis that's closely integrated with a timely dissemination to those who need to know. And this is the clinical community, the policymakers, and in many cases, the general public. Now, this is my translation into English of this complex definition. And how I see it is that it is the process of reliably tracking important health events. So in the after we do all of this information can improve the lives of people. And I think this is the same message coming out of Dr. Linchetto's presentation. The information really has to improve the lives of people. And this really goes back, I mean, every word is important here. Tracking refers to this ongoing and systematic, sustained and sustainable process. Reliably, it means that it's accurate, complete. And this is where some of the manuals that Dr. Linchetto has presented comes along. It's we have to make sure that these things are accurate, complete, and timely everywhere. Important health events, and this is a joint and considered choice by every system. We talk about information and not data, because information is the combination of the data and its interpretation. So you need people on the ground to actually know what these data mean. And that can help improve, so it supports interventions. And how do we measure up success? That's important. The key question is, are lives better now than they were before we started this practice? Now, I would be talking briefly about triple surveillance, but there's much more to it that I will be able to share in these few minutes. So I would be referring you to two main papers, which I have here, and I'll be happy to share the PDFs of these. These papers contain also a lot of the operational details that will suggest how to put these concepts into practice. The concept of triple surveillance came to us when we started as clinicians, listening to the questions that families and communities have when they are challenged with the birth of a child with a congenital anomaly. If you are in clinical practice, you've seen families, you've probably realized that most families sooner or later come up with 5 main questions. And oftentimes they are in this order. The first question is, what is this? What does my child have? This is a question of diagnosis, and this is always the starting point. But then other questions come about, and pretty soon the question will be, what will happen now? A question of outcomes. And how best can we treat it? A question of care, cure sometimes, but mostly care. And then after these questions have been answered, these are the most pressing questions families have. The 2 next ones, why did it happen? Question of cause. And because many of these conditions have sort of a family genetic component to it, what will happen to my family? A question of risk. From a population basis, if we translate this into sort of population health concepts, the first question of diagnosis really comes down to how do we identify and report these conditions? How can we find them? How can we shine the light on a population level on these conditions? Outcomes and care on a population level get translated into indicators of survival, disability, quality of life, and so on. So what are the indicators of outcome? And then cause and risk back to risk factors on a population level. What are the risk factors of congenital anomalies, and what we can do about them? So how do we translate this into action-oriented epidemiology of birth defects in the context, for example, of a surveillance network? The key concept of triple surveillance is that we have to go beyond the evaluation of the prevalence of a certain condition and evaluate the entire causal chain from cause to occurrence to health outcomes. Let me make the example of neurotube defects, spina bifida and anencephaly. The classic surveillance model is the focus on the birth defect prevalence or the disease occurrence. What we are advocating here is to expand the scope of surveillance, both at the roots of it, so the cause, as well as the outcomes, what happens after. Because at the end, the real challenge is not the disease occurrence, but it is the health outcomes that it causes. And this helps us delineate more globally and more accurately the entire burden of disease, which is the combination of disease occurrence and disease outcomes, as well as what I call the burden of risk, the population burden of those factors that lead to disease occurrence, that lead to these health outcomes. And this is important because we have to know these in order to change the natural history of these conditions. We can act, and we should act, on the transition points. We can act on by decreasing the causes, decreasing the burden of risk, and then decreasing the consequences by appropriate care. And so here we have the 2 main concepts of primary prevention, which acts on the causes, and also the prevention of complications leading to improved health through the continuum of care that Dr. Linchetto has expressed. And now, how do we do this? We need to think globally, but act locally. The profile of risk is different in every population, so we have to know it in order to change it, as well as the burden of disease, the challenges of care are different in every population, so acting locally requires local information. We need to have our priorities in each population. And as we can see, we can't do this alone. We have to be willing to communicate and exchange information and collaborate with other partners in order to get the complete picture and act. So again, birth defect surveillance is not only surveillance of prevalence, we have to track the causal change, and this is what we mean by integrated triple surveillance. Let's make again the example of spina bifida. Yes. How do we put this into practice? For spina bifida, we have to, of course, do surveillance of the condition, but also go back to the case. And spina bifida has a multifactorial cause or set of causes, but the most predominant in many parts of the world is folate insufficiency in the population. In terms of healthcare is also the limited care that is available in many countries for children with spina bifida. Anencephaly is universally fatal early on. Spina bifida can be treated, but it requires a whole set of intervention, usually surgical intervention, as well as the need of an integrated team to address the complexity of this diagnosis. So your challenge, our challenge is not only to look at the birth prevalence among all pregnancy outcomes, because this is a condition which includes its occurrence not only on live birth, but also it is a cause of stillbirth as well as of abortions, spontaneous abortions. But if we want to monitor folate insufficiency, we have to come up with indicators of use of folic acid or indicators of sufficiency, which could mean being able to do surveys of the diet, surveys of folic acid use, and surveys of, for example, blood concentrations of folic acid. In terms of health outcomes, this means partnering with teams and systems that are able to look at major indicators, which include mortality over time, but also morbidity, disability, and quality of life. Now, how do we do this? We need to be pragmatic. We need to come up with what we want to do in terms of the ideal indicators, but also of things that can be looked at in a pretty simple and straightforward way, so that we get a general idea of what's going on as we work towards the more sophisticated ways of finding indicators of these conditions. Now, I won't go into the specifics of this, just wanted to, again, touch upon the example of spina bifida and look at surveillance component, the benefits, and what is the added value of integrating into the triple surveillance framework. So the ideal way of looking at the burden of risk is to look at blood folate concentration. This is the main indicator, the most sophisticated, but I think the most sensitive indicator of the burden of risk in a population for spina bifida. By looking at this, we can, for example, measure the penetration of the intervention, which could be folic acid supplement use, or even beta folate fortification in a country. By measuring folate levels in various strata of the population, different population groups, we can measure if, in fact, sufficient folic acid is being delivered effectively to women of reproductive age. Actually, by looking at blood folate concentration, we can help interpret changes of occurrence rates over time. Birth defect surveillance on a population level is not easy, But if we're able to look at blood folate concentration, we know that there is a direct relation between folate concentrations and the birth defect, spina bifida, anencephaly, occurrence. So by looking at this, we can actually predict the rates of spina bifida and anencephaly much more quickly. Folic acid concentration will change quickly after folate fortification. We don't even have to wait for what happens 9 months after. But there are certain challenges like the sample, the selection, lab capacity, cost, and sustainability, but these can be addressed. Again, we can look at neural tube defect occurrence, which is a consequence of folate insufficiency. And this is a direct assessment of a key outcome. And it provides a direct link between the how we address folate insufficiency and the health outcomes. The challenges here, of course, are population coverage, sustainability, inclusion of stillbirths, and elective terminations of pregnancy. And finally, health outcome assessment, the third leg of the surveillance component. This is really the true burden of disease, is what happens to this. And it measures the true value of prevention and is directly usable to improve care. And for this, we need a robust core data set, longitudinal follow-up if available. Now, this is a quick summary of the evidence that tells us the story of the importance of folic acid insufficiency and its direct correlation to neural tube defect occurrence. It is a summary of two different studies, one from China, one from Ireland. And the key point here is that these two studies have looked at folate concentrations in women, and this is on the x-axis here, and the rate of neural tube defects in the population. And as you can see, there is a direct correlation consistent in both studies that as you decrease as you increase the folic acid, the average folic acid concentration in the population, and you get to a certain point, which is about here, and this is the one which we call effectively folic acid sufficiency in the population, the NTD risk comes down from high levels to what we believe is the target for folic acid fortification, which is an NTD rate of about 5 per 10,000. So if we're actually able to measure the folate levels, we can in a way be able to predict what the neural tube defect occurrence is in a population. And we don't have to do this on millions of people. We can do it in a well-designed survey. Now I will skip these for in the interest of time. This is information which is explained and discussed in the two papers, but basically it goes through each of these three surveillance components: folate insufficiency, a neural tube defect occurrence, and it goes through what an ideal state it would be, what the current state is in many parts of the world, that some of these are rarely done, for example, and it provides a suggested roadmap as to how we can start with less complex methods and then expand. And these are some ideas for the risk factor component, in this case folate insufficiency, the birth defect, it's a prevalence here, the neural tube defect occurrence, again the ideal state of population-based ascertainment, the current state with no surveillance often facility-based, but this is a good start. So it's a strategies to improve with a facility-based surveillance in live birth only, and then expand into home births, to other hospitals and other congenital anomalies. And then the third leg, the ones of outcomes. Again, the ideal state is long-term tracking of multiple outcomes. In many areas, no data or limited data. And then how we can do this over time as we build to more sophisticated and more complete. I'd like to conclude here by highlighting that been talking about the example of neural tube defects, but this can and should be expanded to other other conditions. For example, 3 common ones here: heart anomalies, cleft palate, some genetic condition such as Down syndrome, recognizable at birth, and expand also the profile of risk factors in a population that one is interested in. And again, this will change according to your priorities in your part of the world, but these are some common ones: maternal diabetes, a risk factor for heart anomalies, but also for some of the other conditions. Smoking is a prevalent risk factor. What's important here, I think it's a risk factor for certain congenital anomalies, but also other important health outcomes in the population, such as intrauterine growth restriction and preterm birth, for example. It is also a risk factor for adverse outcomes in the population in general and in women of childbearing age. Maternal age is a population level risk factor profile that can be changed through counseling, for example. And again, the health outcomes, I made examples here that go beyond sort of morbidity and mortality. We can look at hospitalizations rate, we can look at intellectual disability, which is an important outcome in many of these conditions. And again, the concept here is to look at the entire causal chain as a way to address, shine the light on the burden of risk and the burden of disease, and provide the basis of intervention across the entire spectrum. So ultimately, I see these as ways to look at the vital signs of population health. We are using the clinical word to look at the vital signs of a baby, the APGAR scores, the heart rate, because this tells us about the current state of the child as well as the risk. Is the respiratory rate what it should be? What is the oxygen level? What is the heart rate? Is the baby, say, moving? Well, triple surveillance aims in a way at looking at this spectrum, the vital signs of population health, that includes not only what's happening right now, but it looks at the antecedents, the causes, as well as the health outcomes. You may ask now at the end, yes, this is all fine and good, but it is a lot. We can do this on our own, and you're perfectly right. The idea here is not to do this on your own, but is to help us think about strategies for collaboration. We have to be realistic. You need a basic infrastructure, health records, training, advocacy, facilities with diagnosis capacity, the availability over time to develop and implement health and democratic surveys. But what I always say, this is true in any place, is to look first, and you might be surprised. For example, when you do the scoping reviews, include also studies on risk factors and outcomes, and not only on the prevalence of conditions. check around your healthcare systems for example, nutritional surveys. Check for risk factor surveys, and these may be done in other parts of the Ministry of Health, other universities not necessarily connected with congenital anomalies. You know, smoking surveys could be done in places interested in chronic diseases. Nutritional surveys and biomarkers can be done in other parts of your world. Check for outcome studies that are going on, even facility-based at the beginning. And again, you might be surprised what you get out of those conversations. And again, you know, talk and be friendly, spend time with other groups that do these things, find common goals, find ways to share data, and begin to plan together. A helpful strategy is to piggyback on what other people are doing in order to add and tweak indicators in a way that will have low marginal cost but can deliver excellent data. For example, there could be surveys that produce data on smoking and diabetes, but they could do it only for men and women, or they could have age group cuts that look at under and over 65. And you can work with them to make sure that they look and be able to give you a profile of women 18 to 45, you know, for example, in the you know, reproductive age and so on. So I believe there's a lot that can be done by looking first and talking and be friendly and being able to come up with common goals and sharing data. So at the end of the day, I would like to close here, and hoping that, you know, next time someone tells you good morning, please do surveillance for spina bifida, for example, that you can start and begin to think in terms of the entire causal chain and think about the concept of triple surveillance. I will close here, and thank you very much for your attention.
Thank you very much, Dr. Boto. I think it really has covered the spectrum of not only the prevalence, but also identifying causal chains so that we can actually do something, triple surveillance, do something to help these children with birth defects. We have some questions in the Q&A, and I thought we may give ourselves about 10-15 minutes to have these questions addressed. And I'll start with the very first one, which was specifically to Dr. Onela. Thank you for the informative talk. As most birth defects cannot be prevented, the public health problem in low middle income countries is the unmet care needs of children with disability and medical conditions. Does WHO have any initiatives in the field of childhood disability? And then we can move to the other questions. Dr. Onela?
Yeah, thank you very much. Yes, in fact, we have a full program of disability in general, not only disability due to birth defects, but disability due to any other condition or accidents and so on. So you might have seen that I've shared in the chat the link to the program. And also to say that disability, we even don't use much the word disability per se, the word impairment, to say that disability is a combination from the condition and the environment. And in fact, environment in the sense, negative aptitudes, lack of devices or transport or limited social support, etc. All of that is is related to you know, how to better address the needs of these children with disability. And in our program, you will find the tools, and will find contacts, etc., on reducing disability in the, you know, and looking only, yeah. So, and the other part is the nurturing care framework. I don't know how much you are familiar with the nurturing care. and which is more for every child actually, but what we have in the nurturing care framework is, how to support parents in providing the best possible care for their newborns and children, and in order, and there are very important inputs there also for children with disability, of course, or with defects. Yeah. Not all children with birth defects are disabled, and this is why I'm trying to say some are not. They don't have disability, but they might have to face stigma or other things. This is why I'm talking also about the nurturing care framework that would be useful, a useful tool to look, and yeah.
Thank you very much, Anita, for that question. And thank you, Dr. Linchetto, for the answer. And I think she shared the link in the chat so that you can actually access it. Lawal and Luke asked similar question. I'll ask Dr. Boto to start them off, that we do have weak or absent surveillance and mechanisms of birth defects diagnosis in some parts. How do we ensure the surveillance is standardized, institutionalized, basically support the government and WHO to place priority on birth defects? I've merged the two questions, Dr. Boto.
Yeah, these are very important questions. Actually, it's a critical questions. I mean, that's clearly to set up birth defect surveillance system, you need the coming together of a number of stakeholders. There has to be some administrative and government support. This is key. One of the key, so I would like to highlight two essential priorities. One is that a surveillance program to be effective has to be sustained, has to be ongoing. So this needs sort of the intervention of a number of stakeholders, including the government. The second, there are ways we can discuss that can be done. There are success stories, and we can talk about that offline. Every country is different, but I believe firmly that birth defect surveillance, effective birth surveillance, is possible nearly everywhere. The second is how to make it effective and standardized. I think this is a very good point. I would like to say two things. One is that this is really important because bad data can be worse than no data at all. So if we collect data, if we invest in surveillance, it has to be done well. It may be focused, it may be done perhaps only in one part of the country and in certain facilities, or only for certain congenital anomalies. But if it's done, it needs to be done well so we can get reliable data for public health action. Tools exist, and again, I would refer you back to the two products that we've developed with WHO and CDC, and that Dr. Linchetto has referenced. One is the manual for program managers, and the second is the quick reference handbook. The main innovation, and this goes to your question about standards, in that we focused in these two manuals on the quality of data. And in order to do this, we developed, for example, checklists for description, checklist for diagnosis, checklist for coding, checklist for analysis. And I think if you look at that, you can find a series of tools that can help address the points that you have just mentioned.
Thank you very much. I don't know if Dr. Linchetto would like to add, since she's speaking from the WHO point, because they were asking how WHO can also support. And also, if you could address Lowell's question about Nigeria, specifically fortification. The premix is not available for folic acid. Fortification is a major problem in Nigeria. No premix. What is the best approach to this? I think both of you can address that, but we'll start with Dr. Linchetto.
Thank you. But for the fortification, you know, if we don't have a folic acid fortification program yet in a country, I think we still have the supplementation as a strategy. So that is has been in use already since some time. And this will be the supplementation in antenatal care, even better in the preconception time. So this maybe is easier to be provided, and I think many countries are already providing folic and iron. So in antenatal care, that is an alternative to while fortification program will be put in place. Yeah, and for the surveillance, I don't have much to add. You know, we really have the tools now. That Dr. Botta was talking about. And now the next steps will be to build the capacity to use those tools, to disseminate the tools actually, and to build the capacity to use them in collaboration with our partners. I strongly support what Dr. Botta said. You know, it's good to start small. It's good to start with something that can be feasible and doing it well. Maybe as some countries are doing, it's better to start in the hospital first and not pretend to do too many things at one time, and act and learn from the data, learn from what done, starting from what is more visible and feasible as well, according to the system of the country, I would say.
If I can add a word about fortification.
Okay, thank you.
Because yes, this is at the end of the day, fortification will likely be the solution for neural tube defects. Neural tube defect prevention, primary prevention on a population level. As Dr. Lincetto had mentioned, supplementation works, but it is quite difficult to sustain. And you need pills, and you need to take them basically every day and before conception. So it works, but it works only in certain groups, and it will not solve the problem. So fortification is the way to go. Now, how to do this? I would refer you to the partners whose essential purpose in life is to help countries implement fortification. I would like to point and invite you to connect, for example, with the FFI, the Food Fortification Initiative. They have sort of the technical expertise. They've got lots of experience in helping countries begin to fortify. I would recommend you look at the website and connecting with them. They've got lots and lots of tools and lots of expertise to help.
Yeah. And just to add that, in fact, that means to move the conversation from the health sector to the agriculture sectors and other sector production. You know, is a different conversation, but it's very, very important to move it. And we as an health sector can provide the data on the condition, etc., and create the advocacy that makes this, you know, other partners, we can mobilize, if you like, the other partners, but other sectors also need to be involved. I saw in the countries in Asia which moved in this direction. That was key, really mobilize the other sectors.
Okay, thank you very much. I think because of time, we will just have one last question. How to do effective surveillance without xenograph, from Bobaka. Thank you so much, especially in rural Africa. Both of you could try and address that issue, lack of sonographs.
Well, you can start with, you can do things without the sonograph first. I mean, there are conditions that can be identified, you know, at birth, for example, or can be without the ultrasound, you mean, without the ultrasound? Yeah, because the ultrasound is fine. I mean, we, first of all, okay, now WHO guidelines recommend, you know, to have in antenatal care at least one ultrasound in antenatal care to identify the birth defects, so the positions, blah, 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 malposition, etc. But even if you don't have that, you know, there are many conditions that you can, you have other means, you know, to, as we see from the presentations, to either you know, you see the birth defects and some of these birth defects when they are born, and then, okay, you can take care of them. Let's say cleft palate or club foot, this type of things. You know, the problem can, these babies are facing a lot of challenges if they are not addressed to a proper center. You know, and a lot of disability can be avoided, prevented by actually recognizing the condition and addressing them at the proper time to a referral center. So just to say a common birth defect. Others, well, I mean, a lot can be done also without the ultrasound. This is just what I would like to say. I don't know, Lorenzo, if you want to add anything on that.
Yes, I would agree. I mean, there's, I would see this as a stepwise approach. You start with what you can do, but you do it well. Again, there are many congenital anomalies, important ones, beginning with neural tube defects and orofacial clefts, and microtion, anophthalmia, microphthalmia, limb anomalies, hypospadias that can and should be identified with a well done newborn exam. So there are at least 10 of these conditions, and if you include all of these, you will be capturing a substantial portion of all congenital anomalies, and you can improve the care. You can address their risk factors, you can improve their outcomes. So, you know, a lot can be done. You may not be able to capture internal anomalies, such as congenital heart anomalies, but you know, those will come. But in the meanwhile, there's plenty that one can do, and that is not currently, you know, being done, and that can help improve the health and the survival of people, families, and communities.
Okay, thank you so much. We really want to thank our presenters for the excellent presentations that have been made, and also address the questions appropriately. And there's still a lot of questions in the question and answer, but we'll try to address them when we have our next sessions. And I think you can also reach out to the Sub-Saharan Africa Congenital Anomaly Network for more details. In the chat, Dr. Linda and Esther also put in how we can join and link up so that we can share and answer some of your questions that we haven't answered today. But thank you. I want to really thank the people who've attended for your attendance and your attention, and also your questions. But I also want to thank our expert panelists who've been excellent, Dr. Boto and Dr. Linchetto. We really appreciate your time and also sharing with excellent presentations. We want to thank you and announce the next webinar is 25th August, and we will be sharing birth defect experiences from different countries. So please come back, but also share with other people in your networks how we can share experiences and learn from other countries, what they've done in the surveillance programs. We also, many of you are asking how to join the network. Please see the link or the email address, and we'll be glad to have you join.